Welcome to the next appointment with the 20-Minute Clinic. My name's Robert Westgate. I'm your locum guest host for today's appointment. And with me in the room, we've got Helena Gregory.
Good morning. Lovely to be here.
And we've got Paul Day.
I'm on the wires and keeping them technically correct.
So Helena, I've done a little bit of research. This is what ChatGPT said about you. So you're a senior pharmacy leader with over 20 years experience across community, general practice, education and commissioning in Cumbria. You lead medicine safety and medicines optimisation work regionally, supporting GPs and pharmacists to deliver safe, more effective and personalised prescribing. And I gather you've got an unusual interest in shoes.
Yes, I do love nice shoes. I have a fantastic shoe collection, so it's great to be out in a nice, shiny, glittery pair this morning.
How does AI know about your shoes? That's quite worrying, isn't it?
Social media.
It knows all.
So, Helena, what we've tended to do in these appointments is just have a little bit of background, a bit of reflection on your journey so far, and then we'll get into a bit more content around what's going on in the world of medicines optimisation in North Cumbria.
So I started out in community pharmacy back in the days of pill counting, back in the days of making ointments on the countertop, slapping the ointments about, getting them made, getting them put into pots ourselves rather than buying it in, and counting tablets in triangles, learning our 28 times table as boxes started to come in as well. So back in the days when it was a really technical profession, working in community pharmacy for a long time face-to-face with people, and started to see some of the services coming in as well that we provide today, such as emergency contraception, smoking cessation, have started to come into community pharmacy much more. So it was really exciting to see that change and becoming, a much more person-centred profession. And then that was a great opportunity to take that to the next step by moving to work in general practice as a clinical pharmacist there, working with patients around their medicines, talking to them about how they use them, what was working, what wasn't, some of the side effects. If it wasn't working for them, what could we do differently? Did they need a different medicine or a different dose? And supporting the rest of the general practice team with that, having conversations. Sometimes we had a little bit more time to sit and talk where somebody's medicines increase or reduction wasn't quite working for them to find out why. And that, years of practice gave me a really solid foundation to move into sort of a more supporting background role, to work in practice support and commissioning, which is where we sort of buy in the healthcare services and help to support the healthcare services to make sure that patient care is the best that it can be. And today my job is very much joining the dots for people. So it's finding, for example, that for a person's lifestyle, they might have cardiovascular disease, and actually part of that is about improving the medicines, but part of it is working with other members of the team within practices to help with their lifestyle. For example, there might be things that they want to do around diet or activity, and we can help them with that. So it's about helping join those dots for people so that it's easier for frontline teams on the ground.
So what does a typical day look like for you at the moment?
I do a lot of data and analysis and intelligence. So in order to join those dots, you really have to understand the different parts of the story. So some of that is looking at the data and the trends and saying, are we prescribing more of the things that really work for people and really help people? And if we're not, how do we help them to increase that? So again, cardiovascular disease medicines are a great example because they have such potential. Same with diabetes medicines. But equally, there are some that we think actually potentially harm people in the wrong situation. So actually, are we prescribing too much of those compared with others? But you have to talk to people sometimes to find out why as well. So speaking to our frontline teams, our prescribing support teams, such as Susie here at Carlisle Healthcare, and, across North Cumbria, is really helpful to understand why practice is the way that it is. What are the barriers? What do we have to do to help to change it? Who are the other people that we perhaps have to bring in, and turning it from a trend on a graph to a story and actually understanding, so that we're not coming in saying, oh, but we must do this, but actually, as a GP, it's not going to work. So there's no point in me telling you that, because it will just be like, oh, we can't do that.
So thinking about medicines optimisation, because I guess that's a large part of what you're involved in. For the uninitiated, what is medicines optimisation? And what are the key priorities within that in Cumbria at the moment?
Medicines optimisation is getting the right medicine for the right person in the right way at the right time. There's a lot of rights there.
It's a good hashtag, though. We like a good hashtag. Yeah.
It's much more complicated than it used to be. So it was just the case of your blood pressure is this, so we're going to give you this tablet and that's going to make everything great for you. And now we realise that actually that's not the case. So there are some people, for example, as you get older, sometimes your body doesn't work quite as well, or they might continue to work really well. We don't actually know that until we check it. But then we have to give you the right medicine that's not going to do you any harm, but that is going to help your blood pressure and help mean that you stay well for longer. So medicines optimisation, it's not a black and white choice. It's not a simple flow chart, but it's a series of questions and principles that we move on to. I work across the northeast North Cumbria, but I do obviously live and work in Cumbria and, enjoy spending my time here outside of work as well. So it's really important for me that we get it right for our population in North Cumbria, as well as looking at the whole wider population. And some of our priorities are around over-prescribing. Are we prescribing too much sometimes to people, particularly where it can cause them harm rather than good? Antimicrobial resistance is a worldwide issue that we have, so we play our part in that. Respiratory conditions, mental health, obviously, which has been in the news and the media an awful lot over recent months. So we have a key focus on that. Pain, we do a lot of prescribing of analgesia for people who live in pain. And of course, as I've mentioned quite a bit in that introduction, around the cardiorenal metabolic space, so cardiovascular disease, diabetes, chronic kidney disease are some of the priorities that we're looking at.
So that's clearly a huge agenda, isn't it? I mean, it's a real breadth of the spectrum of healthcare. How do we decide, or how does the ICB decide where to focus its energies, where it can maybe have the most benefit for the most people?
Yeah, you're absolutely right there, Robert, is we've got to have the biggest impact with the resources that we've got in terms of our NHS workforce, in terms of the money that we have to spend, and keeping people as well as possible for as long as possible. And a lot of that is where the data comes in. So understanding, for example, the amount that we spend. So we spend £65 million last year for the people of North Cumbria for their medicines to keep them well. And that helped about 250,000 people to access the medicines that they needed, which is great. But we have to focus in on those things where really that benefit, either we can increase the benefit, so we can help people stay well for longer by giving them a statin as a preventative for their cardiovascular disease, or antibiotics, making sure we're giving someone the right antibiotic at the right time to help their infection, to prevent it from getting worse. And that can keep people well, keep them at home, keep them out of hospital where, people don't necessarily want to be. We need to make sure that we use medicines when they are needed, but actually to reduce the risk of harm and reduce the waste, both in money and the planet, to make sure that we're not using them when they're not needed. And we can do that through personalising care and finding the right treatments for an individual, preventing illness and not just treating short-term symptoms, and helping patients make informed choices when they come to see us by giving the information so they know what they've got, they've chosen it, and they know how to take it away and use it.
So clearly understanding data and understanding populations is a key part of applying that body of evidence to make a difference to individuals on the ground. Can you share an example where data insights have directly impacted on medicine safety or improved patient outcomes?
We've done a lot of work around lipids for cardiovascular disease. So the data showed that in North Cumbria, although we have very high rates of cardiovascular disease, traditionally we haven't prescribed lipids to as many people as in perhaps some other areas. So it was looking at that and saying, we're playing catch up a little bit. We know that we've got higher rates because our population health data is showing us that, but we know that we're not prescribing as many statins, for example, to people. There are many reasons for that. I think that conversation's become much more complicated over the last few years, and sometimes the risk of it, particularly in the media, has been overplayed, while the benefit of it, that life-saving nature of this, that preventative nature of this in keeping people well, has perhaps been underplayed. So actually people trust their GPs, they trust their nurses, they trust their pharmacists when they come in and see them to give them that information. And actually being able to have that conversation with them and to say, this is the risk to you, I think has been quite transformative. So being able through the Q risk, for example, to have a look and say, for you as an individual, this is your risk of heart disease over the next few years. We really want to keep you well. And for some people where that risk is quite low, they might actually think, actually, that's okay. I'm prepared to take that chance. Or I'm prepared to change my lifestyle, maybe to do a bit more activity. And for other people, actually, where they look at that and they have a combination of factors for that person, perhaps they're getting a bit older, perhaps they've gained some weight, perhaps they're have a different medical condition that might increase that risk, then actually being able to say, this is your personal risk. If there were 100 people like you lined up, 20 of them may have a heart attack or a stroke. And being able to put yourself in that position and say, would I want to be one of those 20? Probably not. Actually, what are my options? And then coming to you as a GP and saying, actually, these are my options. I have choices here. I don't just have to take one thing. I can take from the basket that's available to me. And for you being able to lay that basket out to people to choose from, I think has changed that conversation from you must take a statin regardless of your personal risk. You must take that statin regardless of what it is. And somebody going, but I've seen this headline in the newspaper and I'm really worried about it, to actually the risk of that is really, really low. There are a very small proportion of people who do have muscle pain or who do have headaches as a result. And that's fine, we can look at other treatments, but the vast majority of people, actually it works really well for them and keeps them really well longer term. So that's the example where we looked at the data, we found the problem. The way that we work and have conversations with people has really transformed that for them. But then the next question is actually, how does that fit into my lifestyle? So have I got a medicine that I take once a day in an evening? Now, is this somebody who works a night shift? Is this somebody who works 3 different jobs? Is this somebody who might find that really challenging? Is this someone, this is their only medicine? Or is this someone, actually, this is one of 20, and how on earth am I going to fit that in? So that next part of it is really part of the conversation. Can I swallow the tablet? Some people can't, and we might have to make adjustments for that, or actually it might not be right for them. There might be something else that is more suitable. So I think that conversation's really changed, which makes it more complex. Sometimes it takes a little bit more time to delve into, which is where the clinical pharmacists in general practice doing the structured medication reviews really come in, because they can take that time to pull some of that apart. But sometimes it's just about how we ask that initial question, going from you must take this to actually this is the thing here and what are my options.
It's great how the patient-centred care is pulling in the lifestyle stuff as well now, because I feel like that's not something that's always been the case, is it? That's quite new that they're bringing lifestyle into it as well.
I think it's a great example of looking at the science, looking at what can make a difference, but then turning that into a personalised care conversation. Because you have all the science in the world, but unless somebody believes in what they're doing and changes what they do to make a difference, be it taking a medication accurately or adopting lifestyle changes that are going to lead to health improvements, unless people actually make a difference and do something themselves, then you don't see the impact of the science.
It's that professional curiosity as well, but also working as part of a team. So when I worked in community pharmacy, you were the leader of the team, but you quite often worked in isolation. Moving into general practice, obviously you've had that traditional pharmacist, doctor, nurse kind of work support, physiotherapists, paramedics, occupational therapists, dietitians have been coming into general practice, and that means you've got other people who wouldn't have been there before. So for example, as a pharmacist, I'm not an expert in fitness, but if somebody comes in, then I can signpost them perhaps to the social prescribing link worker who might be able to support them into that activity. I might have that list in front of me. Actually, what is available? There are wellbeing walks, for example, that people can just join up, meet other people like them. So it's doing it in a way that's manageable and supported for people to get them into that. And hopefully then they'll enjoy it, go out on a sunny day, have a bit of a chat and think, actually, I quite like this. I'd like to go off on the bus and do it on my own.
Becomes the new lifestyle,
Here
That's
comes the change.
And there's something about that personalised care, proactive care conversation that attempts to unpick barriers to enable people to decide what's right for them, to then lead to changes to make a difference.
Yeah.
So it's a very different conversation rather than this is the tablet, take it twice a day.
Yes.
To unpicking that and recognising that, is it 30 to 50% of people don't take medications as prescribed? So if we believe we're prescribing stuff, that people then are not taking as we expect them to, we're just missing a trick in terms of that personalised care conversation and understanding what's actually going on the ground.
That's very true. And I've been into so many homes of people when I worked in practice where you would see they would have piles of medicines in front of them and often not know why they needed to take something or feel that something wasn't working for them or was causing a side effect that they felt they couldn't tell somebody about because they felt that they might get judged. So actually changing that conversation to say, how is it working for you? It's okay to have this conversation. It's okay if it's not working because there are choices here that we can make depending on that circumstance. So it's very much, I think, that professional curiosity has opened up conversations with people. And a lot of people do still feel that they might get judged if they say that, but message to patients out there is please, if you're taking a medicine and you think it's not doing what you want it to do, then please mention, because your healthcare professional will be more than happy to have that conversation with you and look at what your choices are.
This is a slight change of tack, but we live in a very imperfect world. Despite everybody working really hard and loads of people trying to do the right thing. So this is a question about health inequalities, really, and the role of medicines optimisation in addressing health inequalities, thinking about data, thinking about populations, thinking about how we can target intervention to support people with the most need. Just to sort of inquire about your reflections on the role of medicines optimisation in narrowing the gap of health inequalities in North Cumbria.
Recently, we've started looking much more at the quality impact of what we do and also the inequality aspect of what we do for different cohorts. So we might look at our population for the North East and North Cumbria and then equally locally for North Cumbria and understand the makeup of it, understand what types of people live here. What kind of social aspects have we got? Do we have people with disabilities? Do we have people who are older, people who are younger? Particularly in North Cumbria, we do have an older population that by and large is not as well off as some other areas of England. So we have to make sure that we're planning for that. And that's where the strategic role that I'm in, we look ahead at that. We look at our population and say, actually, they are older. And therefore, we're going to have more people going into hospital. We're going to have more people ageing, more people needing social care, more people, very sadly, will be dying over the next few years. And we have fewer younger people, so perhaps we have less healthcare workforce coming in. Some of that looks at the population and the way that it goes, and some of it looks at the targets within North Cumbria. We are aware that we have a very rural, remote population here. We do also have cities. We have market towns as well. So we have quite a wide range of people. We have to make sure that the care we provide really works for those different groups. So actually something that works in the middle of a city where you might have one site providing a service may not work in a rural area where actually you need a number of local areas. So I'm thinking of Newcastle, for example, in the northeast, where somebody might say, I have one site providing this service for the whole of Newcastle. Actually, it has very good public transport links. If I'm providing a similar service in Cumbria, then actually I might want to have more than one site to be able to deliver that. And that's where it's great, general practice and community pharmacy really comes in to support some of that care locally to home.
Obviously, you've had an extensive career in pharmacy, starting off in clinical pharmacy, then moving into more strategic roles that are supporting the wider system and making a difference. For someone considering a career in clinical pharmacy or meds optimisation, particularly in a rural community like North Cumbria, what advice would you give to someone starting out around career choices or thinking about choosing a career path in pharmacy?
Pharmacy is fantastic as a career because whoever you are, whatever background you're from, there are different options and different pathways to get there. there. So I'll start with the pharmacist role. I'm a pharmacist, and that is a very academic route. It's previously been much more technical, and there is, of course, still that scientific aspect. It is a science degree that you do. But you can now also have much more of a people-facing role. It has really changed in the last 20 years. So I think being able to be a people person, build relationships and speak to people, and be able to explain very complicated concepts, that medical evidence, in a very simple way that somebody understands in their day-to-day life, I think is a real skill. So to do that, you work through the academic route. Science A-levels, for example, are usually the best route, and then you're applying to university for a Masters in Pharmacy degree, and you then do a pre-registration year, which gives you that time out working in practice before you get your final professional registration. The other exciting pharmacy profession is pharmacy technician, and again that has really changed as well. So it's gone really from being that dispensing assistant role as it was 20 years ago to being a much more operational support role now, and it's fantastic because pharmacy technicians really understand systems and processes and how things work. You can learn on the job, so you can work in a hospital or a community pharmacy, work from dispensing assistant to gain your NVQ qualifications. So it's on-the-job learning. You're not having to go away to university. So if you prefer a much more hands-on kind of training, then pharmacy technician is for you. They're doing many more things now. So we have pharmacy technicians working in general practice, and they will be doing a lot of the support around structured medication reviews, and also quite excitingly now as well, they are working to help people understand how your medicine works for you. Does it fit in with where you are? And providing some of that linkage between the clinical pharmacy aspect and other members of the multidisciplinary team.
If you could ask one thing of every GP or pharmacist in North Cumbria, what would it be?
I don't know if I've already said the word professionally curious too many times in this podcast.
Nah, you can't say it too many times. It's fine.
But yeah, it's to, I think, ask as much as you tell, to make sure that, is someone happy with something? Is it working for them? Because it doesn't take any longer to ask the question and somebody say yes than for you to tell them and they go yes because they think they should. So yeah, professional curiosity is, I think, a skill that I've developed over the years as I've become more experienced and gone from I can see how to apply this to actually I need to learn how to apply this.
One of the pieces of work you've been involved in is around looking at last years of life. So we often think about sort of living well and using medications to, improve health outcomes, etc., etc. But last years of life, there's something about living well in those last years of life and also thinking about dying well. So can you tell the audience a bit about the work you've been involved with around the Deciding Right framework?
So we both sit on the North Cumbria Palliative and End of Life Partnership, working with different organisations. Obviously, we have that understanding of how complex care can be, how many different clinicians can be involved in somebody's last years, months and days of life, and how that care becomes more complex and we have to help them navigate it much more effectively. It's not a simple flowchart. Some people might want to make a decision that actually the length of their life is really important to them. For other people, it might be their quality of life that's really important to them. They might have something in particular that they really want to get, a big life event or experience that they want to get in on their bucket list. And being able to help them do that, no matter how large or small. And then medicine's helping them towards that. We have the Deciding Right framework, which is really helpful for that. So it helps people, for example, to make advanced decisions to take or to refuse life-sustaining treatments that they might not want. CPR, for example, has been the one that we've always thought of. But there are other examples through the Rethinking the UK's Approach to Dying report last year around severe respiratory infections, and that actually someone may choose not to have antibiotics or steroids where they ordinarily would, because we give them course after course after course. And they're very unwell and they feel that actually that's not the right thing for them. They would value that quality of life in that case over that length of life. And that's down to the individual. So I would recommend that people have a look at the Deciding Right website and work their way through it. There are some really good symptom control guidelines as well, which are being updated at the moment. So we'll look forward to those coming through.
So there's something there around improving the narrative with individuals and personalised care at the end of life, but also strategically supporting healthcare professionals to have the tools and resources available to inform them as they have those better conversations. So Helena, thank you so much for your time.
I've got an extra question.
Fire away, Paul.
Even though I feel it's going to put us in extra time of our 20 minutes, but is it a specific week that we're putting this out on, potentially?
It is. It's really exciting. It's Medicine Safety Week this week. It's run by the MHRA and it's having a look to make medicines as safe as they can be. And one of the big messages is we can only make them safe if we know about the problems. And the best way to know about the problems is to make sure that things are reported. That might be safety incidents and what we learn from those, what happened to reduce the chances of it happening again. But also there's a national system called the yellow card system, and any healthcare professional and indeed any person or the carer who are taking medicines can report via the yellow card scheme any side effect of any medicine. You don't have to know that that medicine caused that side effect. You can just think maybe it did. You can go online and do a report for that, because all of those are gathered from around the UK, and then we take those in and say actually what's working, what's not. Are there particular patient groups? So there's some really exciting work going on at the moment around genetics to say, how do our genetics affect our medicines? Then we can take that personalised care a step further and say we can personalise these medicines for you. Actually, based on your genetic code, we recommend that you take medicine A rather than medicine B.
So Helena, I think our time at the clinic is over. So it just rests with me to say thank you so much for your time and contribution this morning. Thank you, Paul, for keeping all of the tech correct. And please join us next time for our next appointment at the 20-Minute Clinic.